was the new part, which we really hadn't had anything written down in a document, but it was one of the 2 performance standards that the Joint Commission had called out. So I really give credit to our director of neurology, who's an epileptologist, and our neurointensivist, Dr. Basit Rahim, Dr. Parshad Doris, and our intensivist who, looked through this information and then, helped us construct this neuroprognostication. So neuroprognostication should not commence until 72 hours after return of spontaneous circulation and or return to normothermia, and elimination of major confounders such as sedation, neuromuscular blockers. We use a multimodal approach, right? It's not just one thing. The clinical exam is paramount. Centers can use SSEPs. You have EEG monitoring, biomarkers. So we do use neuron-specific analase levels. And so the higher level, is predictive of poor neurological outcome. And then imaging, CT and MRI. So these multiple ways of determining neuroprognostication was set up in our protocol. So we have a target goal. We even have a section that just has definitions and assumptions, right? So what is the definition of coma? Dr. Romer Giaccaden out of Johns Hopkins, his lead article, was a great source for us for looking at different types of definition that we could incorporate into our hospital-based protocol. Clinical assessment, what makes up that clinical exam? What are the physicians, the providers who's determining that clinical outcome? What are they looking at? And so what are those criteria that are indications of poor neurological outcomes? So the coma, the pupillary light reflex, corneals, absence of spontaneous breathing, heart rate variability, et cetera. EEG monitoring, there are recommendations on, what are predictors of poor neurological outcome. And in our protocol, we state, put the rapid response EEG, then pull the full comprehensive montage. Epileptologist, neurointensivist, neurologist monitors the EEG, and then they determine the appropriate medication administration. Blood biomarkers, so having parameters for the NSAE levels to be drawn, and then imaging the CT and MRI. And so what are those recommendations of that look like, that could demonstrate poor neurological outcome?